busy these days, but
It
thank you.
is.
A lot going on.
Sure is.
Lot going on. Hi, everybody. Look at your beautiful blue, Jean. I love it. And Paula's nice and bright with her red.
With my red. Yep.
I like it.
I told you my story about blue. Every city hall I've ever worked in, they painted the walls blue, and it was like the color of the bottom of the swimming pool.
Yeah. Yeah.
It gave me averse to blue. And so my goal has been to try and like blue. So I wear blue. I force myself. And my mother always says, you should do that more. Blue is your color. And I'm like, oh, blue. All those city hall walls. Robin's egg blue and
Yep.
swimming pool blue. These beautiful historic buildings painted this color. But thank
Hi,
you.
Jerry.
Hey, Jerry.
Hello, Jerry.
Hi, everyone.
Okay, well, why don't we get started? Hi, Christine. Welcome.
Hello, good evening.
Oh, hi, Christine. It's Paula.
Hello.
So why don't we call the meeting to order? Tonight, we're going to go through the usual public comment, review of the minutes that Peter sent along. Kevin's going to give us an update from the coalition. Jean will give us an update on the budget process. Peter, since it's the first Thursday, Peter's doing the monthly health division report. And then we have the COVID updates as before. And then I thought we could just spend some time thinking about what the year looks like and where the board should be focusing on, or where we think we should be focusing on. So we can get into some detail around that. So with no one from the public on, and Peter, you didn't get any emails, right? No.
Correct.
Okay. In terms of the minutes, those were sent out. Any comments, edits, changes?
Yeah, I have one.
Okay.
When it was talking about the clinics, it talked about patients, and I just thought that mightn't be the best word to use. That maybe recipient or resident might be a better word to use,
Okay.
because they're really not patients.
That's a good point. So that's under the COVID vaccination update. Yeah.
Yeah,
Could I suggest client?
that could be one.
Client. Okay. I'm good with that. Any
Good point,
other
Paula.
good pickup? Any other edits? Nope. Okay.
Oh, nothing else.
Give a motion. I'll present a motion to approve the minutes.
Second,
Second, roll call. Paula,
yes, please.
Carrie,
Yes.
Rick, yes. Approved. Okay, moving right along. Kevin?
Mm.
Oh, Jean, actually. Yeah, Kevin.
Okay.
Kevin, update?
Yep. So I attended the Reading Coalition for Prevention and Support. It's tough to get used to that name. I'm so used to ACASA. Last week. So there were a couple of things that I definitely wanted to update the board about. This one in particular is designed towards mental health. So there's a company called Doc Wayne. I don't know if anybody's heard of that before. And it's for the most part, they work a lot with kids through different means. A lot of times it's through sports, but it's kind of can be therapy, organized therapy group-wise through extracurricular sports after school. And I've known about it for a couple of years now because they've been trying to get the elementary schools in town, Wood End being one of them, where my kids go. So we've kind of heard a little bit about it, but it's a really interesting concept where if you have a group of kids that are really struggling and not just from a mental standpoint, but it's tough for them to focus. It's really driven behind leadership and support and prioritizing things. And it's more for families that have a child they feel like it's just not getting all the support they possibly need. And this is like an external support mechanism. And so I know they're trying to run it at all the elementary schools. I think the middle school as well too, but I'm not positive about that. I know they're trying to get it up and running at the elementary schools. I think just right now, more than ever, it's probably a critical thing. I'm sure there's some kids really suffering out there. I'm sure grades are suffering because of mental stresses that are going on in their lives right now. So this is designed towards that. It's like I said, group therapy. It's also individualized, but they go after the group therapy through extracurricular sports after school. So it's a lot of leadership, a lot of inclusion tactics that they're using. Certainly working with each other, problem solving, and it's a pretty useful tool. I know the coalition wants us to press it out there as best we can. Again, so it's Doc Wayne is the name of it. If anybody's interested in looking it up, and they are an excellent organization. I know they've been around for a while, and they had the person who's the chief of staff over there came out, Jonathan Baum, to present to the coalition last week and detail it. So it says here in the program, it offered at 23 different sites, in person and virtually. In spring 2020, it had 2,000 sports-based group therapy telehealth sessions, and they currently serve over 500 students each week. So it's something that's been around for a while and it's been doing a lot of good for a while. I should probably just
If people are interested in finding out more about it, should they contact the coalition? Should they contact schools or the organization directly? Do you know?
They could contact any of those three. We'll
Any
lead
of those.
them in the right direction. Yeah, certainly.
Perfect.
All the elementary schools, all the principals and teachers are aware of it. Certainly the coalition is. And if I can figure out where is my screen share here? I'll pull this up real quick. Let's see if it lets me. Sometimes Apple doesn't like to play. Okay. So this right here is the little, one of the little flyers that it comes with.
Yeah.
So if they want to get in touch with Jonathan Baum directly at docwayne.org, you could do that as well.
Okay.
The other piece they were talking about that night is this Elliott emergency COVID-19 grant for mental health. So this is something they were able to secure. And a lot of it is mental health, substance use, crisis evaluation, short-term individual group intervention stuff. So it's really, it's both substance use, but it is also has an eye towards mental health. Which is something the coalition really wants to focus in on a lot, and I'm glad to hear that. I think that's something that's certainly going to be needed over the next few years. This is another program that they got through a grant that they're kind of rolling out right now as well. And it's funded through COVID-19 pandemic funds. I'm not sure if it's federal or state, but it's a great program again, aimed at mental health. So there's a lot of that was the big talk, obviously, of the meeting.
Mhm.
And again, just tying in his more.
That's great.
Riverside Trauma Center is another one that they're promoting.
Since most of us have PTSD at this point.
And I think that's probably the only update, other update. This is just all some other letters and stuff. Those are really probably the main two that we talked about that night was the LA program and this Doc Wayne program right here.
So is this brand new to Reading, or has this been going on and this was like an update?
So this was rolled out, as nearest I could tell, was last year was the first time at least I was made aware of it. Because we get the emails from the school about new programs, and they and they push it out there. Yeah, so I think it's fairly new to Reading, because I hadn't seen it in the years past to that, but it's not new as far as its concept in the nonprofit model that it's operating under.
Okay, great. Sounds terrific.
Yeah.
So can I ask a couple questions?
Shoot.
So the focus, this stuff is all direct service oriented, and that's great. Did they talk about any sort of community-based activities, more resilience oriented and community positivity, for lack of a better word?
So I don't think I'm understanding the question 100%, Kerry. I mean, they're always looking for outreach, so they work with schools, they work with the library. You know, they'll go present to anybody that will listen to them. I know they presented to the clergy here in town as well too. So that's an avenue that they're hitting. So I mean, they are a kind of a broad-based outreach. Is that what you're looking
Yeah,
for?
so
Or?
the three that we just saw, the Riverside, the Elliott, and the Doc Wayne, those are direct service supports for specific to mental health, right? It's
Correct, right.
engaged in individual or small group activities. And I was just curious if there was any discussion about kind of broader community-based interventions or thoughts. It's a big question, but like things like I don't know, did anybody else play with the there was a neighborhood thing and people were posting pictures in their windows as kids were going out, and the parents were taking their kids out so they could spot follow members, so they could spot shamrocks or whatever, you know. I mean, those are small homegrown things, and there's been some talk nationally about what can you do like that supports a community. And since our CAS is so advanced, truly, I just am curious if they talk about it.
So nothing like that came up in this meeting. I'd be surprised if Erica and Sammy aren't doing things like that.
Yeah, that's what I was
you know,
curious.
they're usually, like I said, if you'll listen to them,
They're amazing.
and they'll try to figure out a way to get you to listen to them, even if you don't want to. So they're pretty active in the community. But that didn't come up. Yeah, it didn't come up in this particular meeting. I know again, I think we've talked about this before, but they have rolled out last year, maybe it's about 18 months ago, roughly anyway. They had a program now through the Reading Police Department where the police can identify certain calls, right, that are coming in, or cases that are coming in, where they're saying, hey, we're going to have somebody from this organization contact you, just so you're aware. And it's a great little follow-up, and they've been every month they've figured out ways to increase that call volume. So there's things like that I know that they're doing. Again, that's more the problem comes to you when you're making sure you're handling it, which I think you're looking for the opposite, which is let's go out and kind of spread our wings out here and let's prevent the problem from occurring in the first place. I know they have an eye on that, but that just didn't come up in this meeting.
That's okay. Thanks. Yeah, I'm
problem.
sure they do. And so next time you can ask them about it. It'll be
I will actually bring that up.
conversation.
I absolutely will. I'll write that down right now.
It's as I said, they're so talented that
They are
They really are.
dynamic, quite
amazing.
dynamic. Yeah.
And that's all I have. If you have more questions, happy to answer them.
Any other questions or all good? Okay, thanks, Kevin.
Okay.
Jean, any budget update?
Thank you. So the budget is with the town manager. He is required to submit the budget to the finance committee by February 28th. So that's when it's due to the finance committee. And then the finance committee will hear that budget along with some of the other town side. March 3rd and March 10th are the date of the finance committees when they're going to do the town budget. I'm not exactly sure when public services will be up. But I think I might have mentioned the finance committee meets on the 24th. And that is, I believe, going to be schools. But Jackie, correct me if I'm wrong on that, because I know you have your ear to the ground on that one. But That was my understanding, is the 24th they're meeting and they're going to talk about schools. All right.
So Gene, FinCom hasn't met yet to discuss health division? Okay.
No, the meetings that are scheduled for the finance committee to do public services and other town budgets are March 3rd and March 10th.
Okay, great. All right. Moving right on. Peter, monthly report. You're on mute.
Thanks for that too. I was saying thank you, folks, for recognizing me, and I was on mute, so I start all over again. Thanks for recognizing me, Rick. And in your packet earlier this week, you received, among other things, 2 worksheets that were sent to staff, Laura and Daniel. One was entitled, for the month of January, the complaints that we have received, and the other was for all the inspections that we've done so far. And I think they could be helpful. I'll take your, your comments. And Laura responded earlier this week, but I must have dropped it because, and it's a good thing we had a staff meeting earlier today because I was asking her where, she said, I sent it. And so sure enough, she sent it again, and now I have it here. I'm sorry I didn't share it with you. I'm not sure if I can screen, but I'll just go through what's cooking. And this is a project that's in progress, and this report I think will get more refined. But before I start rattling off numbers, is this okay with you folks on how I laid it out in a worksheet fashion? Just everything the equal signs, and then the staff would plug in. The number of, so if we went down the line, the first point was number of 2020 application renewal sent, and there were 165 sent. And then the number of 2021 renewed permits issued, we received so far 99, and there's 11 pending. If I had some more time, I would have asked, so that's 110. We sent out 165, so there's 55, and I'm not going to take comments on any of this stuff right now, but I don't mind you commenting on the idea of, does this work for you? Is this something that you had in mind at the beginning when we were devising the reporting template?
Well, go ahead, Carrie.
Sorry. I love the list. I'd love to see it in a table format. And I know I had asked if we could do it cumulatively so that, it's January through, and we'll end up having to make it a horizontal layout to fit it all. But I think being able to compare, see trends would be great.
That can
But-
easily be done.
Oh, thanks,
This is
Jane.
month 1 of, what will be
Right.
just a running. I wanted to start it off simple enough so we could just
Yeah.
kind of fill in the blanks, and then I'll adopt it into in an Excel spreadsheet, and we should be able to see some trends.
Yep.
So, okay, there's the first piece of feedback. The format is okay, but eventually we'd like to see it in the table form.
Yeah. A lot more detail than what I remember reports have before, much more specific.
Okay, I was at first thinking you want more details because, we did have a re-inspection. Again, by next month, I should be able to have more information. I'm asking now too for inspection sheets. But if your request, Paula, and I don't think it was a request, it turns out to just be a positive
comment.
Thanks.
Just a comment.
But when it comes down to, let's see, can we have some more information on the names of the places that we're inspecting and what are the violations we're seeing? I'm not sure if that's, good
I thought we
information.
had- I'm
Go ahead.
sorry. I thought we had discussed that earlier, not really wanting to put a specific place,
Correct.
name a specific place because the minutes are public. Am I correct, or am I?
Yeah, I think that-
misremembering?
Yeah, I think that's what we had said. And I think we had also said that, and you have number 6 here, number of re-inspections. You know, I think if an establishment has had to have several re-inspections, that might be something we would want to discuss. But, you know, one re-inspection or maybe
Right.
even 2, it would just be noted. But whether or not I mean, if there's a problem institution or establishment, then we should have a discussion about it.
Yeah, I thought it was like anything more than 2 that we had to, and there were some actions taken, then
Yes.
that was,
right.
yeah.
I think that was right.
Well, I think that's wise, and I'm happy to, let the staff be the staff and only bring to the board what really requires some board, review or, from another level. I mean, you're right. If we're getting establishments with violations that are critical, and it's been my experience in the past that, you work with them for a while, but after a while, it's like you have to come in for a public hearing. And if that doesn't motivate them to invest a little bit of whatever is required to make the difference, then I'm not sure what is going to motivate them. But, it's at that point when before the board in a public meeting that they said, oh boy, we should have been listening to our inspectors earlier. And I'd like to keep it that way at that level, if that's okay. So
Yeah.
going down the line, there's been 16 inspections conducted so far in the month of January, and I got some good feedback. It doesn't seem like much to me, but I got some good feedback from Daniel about that. And Laura has said that this is actually ahead of time because of the schedule that goes on annually. Daniel said because of the COVID in late fall of 2020, they didn't get the inspections until late in the year. And so now it's not been even 6 months. So I think we'll probably see the numbers pick up like the next month, and then, the end of the first quarter here, we'll get, 16 will go up. Gene earlier today asked, are we on target to get all 165 establishments that we sent out renewals to inspected twice a month? And we were assured by Laura that, this is feasible. It's going to happen. So I'm going to ask the board to be a little more patient, at least for another month. We can start to sort through this a little bit. We did have 2 re-inspections, and really nothing else compelling about the food establishment report. And but a couple of months ago, I said it's not going to happen overnight, but give me till the first of the year. So here we go. It's taken a couple of months to put into perspective, and I think as simple as this one appears, we're on the right track. And I'd be happy to hear any other comments from you right now.
Jane?
Yeah, I just to clarify, the food inspections that want to be inspected twice a year.
Correct. Every 6 months is the
Yeah,
regulation.
I think you said twice a month, which I just want to
Oh,
make
did
sure.
I? Okay.
We know what you meant. We know what you meant.
Yeah, well, thanks for that.
Can
I
I,
haven't had my glass of wine with dinner yet, so I don't know where that came from, twice a month.
Jerry?
point of clarification, is that annually, Peter, or is that on a fiscal year? How does that time period run?
Well, the code simply says at least every 6 months.
Yep.
And so we're trying to get in the rhythm that, okay, January starts us off. So that
Yep.
means from January 1st until the end of June, we should have them all down and logged in and find out where we went. Then we begin the process again.
Yep.
And, sometimes it runs a little more smoothly than others. It depends on, what's going on with swimming pools in the spring.
Yep.
And all the other permit inspections that we're required to do. And then there's the all important, level of complaints that we get.
Yep.
And I'm not getting a lot of feedback on complaints. We've had, since I've been here, a couple of, and they really haven't been very controversial, housing complaints. That's chapter 2 of the state sanitary code, which in my opinion is the most challenging of all,
Yes.
especially when it's owner occupied. And, you have to get in there and help people. And this is the hoarding piece, or the neighborhood, working to try to get somebody to improve the private property. And and I know the town has another bylaw that runs parallel with chapter 2, and that one helps confuse us a little bit because we were trying to use chapter 2, sections of the sanitary code to enforce the vacant lot
Yep.
bylaw, and we're working that out. And Jean's
Okay.
been helpful too in getting fire involved and building involved. A lot of this stuff is not a health hazard, it's an eyesore. That's as much as you can say about it. So there's the kickoff for these reports. I also have, which I didn't send to staff, another similar worksheet that talks about the numbers of permits. Laura keeps a running spreadsheet of the permits that are out there, dumpster permits, and it's all mixed into one. It's very difficult for me to track. But so I'd like to see us eventually morph that into separate entities. And there are some establishments that will have more than one permit, and that I get. But it's got to be easier to manage than what we have, or at least what I'm seeing here on one little screen on a laptop. I don't have the luxury of looking at two screens and tracking back and forth what the heck are we seeing. So I was going to wait till next month to get the permits, see if we can iron that out. And by that time as well, we should be seeing a little more data coming in, and that will help us understand more about how our inspectors are working and so forth.
So Peter, a couple points. One is that I like the idea of putting this, as Carrie mentioned, into a table or a grid with a column that's this month and then a second column that's year to date, so we can track those. And I don't want to leave off the emergency preparedness and the epidemiology components of this monthly report. This is really about the environmental issues, but we had those two other sections that hopefully next month we'll see some data on, either from Maven or around the emergency preparedness, the goals, I think, that Carrie had mentioned.
Thank you for remembering that, Rick. Yes, absolutely. I'm remiss for not having noted that. Yeah, absolutely. I mean, we're bound to deliverables by the state, and there are funds that we receive in to support accomplishing those deliverables. And I would like to know where we are. What are the deliverables, and where are we on them?
Right, I agree.
Okay, so that's if I may just chime in here for clarification. Because now next under item 8, we're gonna, and every month we do get the updates on case counts and pertinent incident command updates. But when Carrie said something about deliverables, I guess I'm gonna have to tune in. And I did remember all those pieces, Rick, but I sort of think that the agenda covers that. What am I missing? So maybe we'll run it by me again.
Well, I think in terms of the epidemiology, you're right that obviously the big elephant in the room is COVID, and we hear that twice a month and so forth. However, the other part would be a report out from Maven about other infectious conditions that have been identified in the town. That would probably be mostly what that section would be about.
Yep.
Truthfully, and this is coming from who's thinking about infectious diseases beyond COVID?
No,
And-
but
They're still there.
Yeah, but
They're there.
I'm sure
No,
they
They
are.
haven't left.
I'm trying. I
Okay,
think
so
yeah,
now I
there were
get
a
it.
couple of TB cases a couple months ago, I think.
Okay.
Yeah. So you're absolutely right.
Some hepatitis C as well, and
Yep.
varicella.
Okay.
and varicella as well.
Varicella, interesting, yeah.
Mhm.
Okay.
I've been trying to take walks like everybody else, with my wife, and so when we're out walking, this happened the other day. Everybody's very social distance conscious, and so oftentimes when you see someone walking towards you on the sidewalk, you'll see people cross the street to be at distance, or you'll cross the street to be at a distance. And it occurred to me that wouldn't it be ironic, given how many times people are crossing the street, that they're doing that so that they don't get sick from COVID and then they get hit by a car?
Right?
And so,
It's true.
and so the point about the epidemiology is that, yes, there's COVID, but there are other things that can cause harm. And we just want to know about it.
Yep.
Okay, duly
And-
noted, and we will see that beginning next month too, with a little help from Christine on the Maven piece, just as a monthly summary.
Okay, great. Go
And
ahead.
then regarding the EP stuff, the deliverables will be, so for example, you have to do a certain number of call down drills. You need to submit your emergency preparedness, your EDS plan for review. You need to demonstrate that you can log into WebEOC, and you need to provide the information of who are the responsible parties. There's a contract, there's a list. And those are important things, and I think it would really benefit everyone to know a little bit more about what the emergency preparedness responsibilities are. There's a lot of detail that goes into, as you know, Peter, there's a lot of detail that goes into being able to mount effective preparedness plans, and it's that kind of thing.
Yep. Okay, we're moving forward in the right direction here with a couple of reports, and I'll get the others going. Just for clarification with everybody else, and the ones that Kerry just mentioned, that's not a monthly update. They may be a couple times a year we need to do that. So, we'll just keep our whistle wet around this part of the discussion, and it'll be duly noted.
Peter, I vaguely remember you mentioned about some kind of software that we were trying to implement in the division to track permits, and that would help with this reporting. How is that going, or is that going?
Well, we got up the steep part of the learning curve with technology, and then it flattened out. Let's face it. As the winter continued, we saw the couple of spikes, Thanksgiving, again in Christmas. They're predicting another one for Super Sunday. It just takes the resources and sucks them dry, if you will. But we have a foundation there. Daniel was working with IT, and I think the next part of the of Section 8 coming up, we'll talk about the civic permits, and that's all being done very nicely on that same software. And I fully expect that once we get past these prep mod growing pains, you'll hear a little more about that in just a bit. Swang is here. That we can focus again with IT to get this permit software, and really all the inspections and the types of complaints to come out of IT in a format that we're all comfortable with, a consistent format.
Great, good. Okay, well, why don't we go to the COVID updates?
Okay, and then we turn it over to Christine, I would say, from there.
Sure. And hello, good evening. And if I could also just make a quick comment with regards to monthly reporting on epidemiology. There is a report that I run, and it does give the statistics on other diseases to report. So I will start including that in my monthly report as well.
Great, that would be fantastic.
Thank you.
So over the past 14 days, there's been a decline in the number of active cases. Reading is now in the yellow. According to Maven and an internal audit, and also to note data is subject to change, the total case count from the onset of the pandemic to the present time is 1,583. The current active case count is 154. That includes today's cases. The active daily case count is averaging around 6 per day. Total deaths are 46. Total transferred cases are 10. excuse me, with regards to school data, Reading Public School High School has 2 active cases. The middle school has 2 active, and the elementary has 4. 3 are students and 1 is a staff member. Austin Prep, they have 4 high school students, and after speaking with the head nurse at Austin Prep, these cases were not school-based transmission or determined to be school-based transmission. I also spoke with Mary Juliana at the high school, Reading Public, today, and she did update me with regards to pooled testing and where they may be going with that, and will keep me updated. With regards to sports, I do not have anything to report there. And with regards to clusters, Christian Co-op, currently working with Eileen Taggart, was the administrator there. There are 4 active preschoolers, and the class is being quarantined. And I also just wanted to give a brief update with regards to my contact at the CTC. I had a meeting with Sandra Aronson. She has updated me that the CTC has agreed to begin identifying candidates for monoclonal antibody testing. So I will keep informed on that. She also informed me of a public forum that I would like to discuss with the nurses and the staff that is going to be on February 9th next week. And this public forum stresses the importance of people doing their part in participating in contact tracing. In other words, when the call comes, whether it be from the public health nurse or the CTC, you know, if individuals could really pick up the call and participate, it makes the investigation process a lot smoother and more efficient, which also helps data reporting. That's all I have for this evening.
Paula, you got it?
Yeah, Christine, have you had a lot of difficulty with people cooperating with the contact tracing?
Yes, I would say I've had a meeting with the school nurses as well as Elise, the senior nurse advocate, everyone that works Maven. Over the holidays, we encountered quite a bit of I don't want to say non-compliance, but I would say not a lot of callbacks for follow-up to close cases out. And, you know, I'm not sure if it was the holidays and people not feeling well and it just being a busy time of year, but I would say we've not encountered that. It sort of began, I would say, right before Christmas, going into right after a couple of weeks after the new year. But to the point that all of us did meet about it to discuss it, and just how to handle follow-up if we don't receive a call. What we decided is we place the call when we're alerted, and if we're not able to reach that person by phone, we're not waiting. I'm going to go out and send an isolation guidance with my phone number on it to return the call to the public health nurse. If they don't return the call, you know, we'll give them another follow-up call, but otherwise we can't keep people on an active case roster. It sort of takes cooperation on both ends, but in order to close the cases out in a timely manner, it is helpful to get their cooperation. Otherwise, we have to put that the case is lost to follow-up, and we really don't want to do that.
Right.
We want to try to keep as much of the data on point as we can.
I'm just wondering what we can do as a board to kind of help support you in that.
Yeah.
Some sort of a PSA or something like that.
Yes, I do support that. I'm open to suggestions because I honestly really cannot come up with a particular idea, but maybe just, a reminder to the public that the importance of answering the call, or
So what, if
Um,
I may ask, what is your recourse with other diseases like tuberculosis or
yep. So with
salmonella
that,
or something?
yes, and so with that, we do require cooperation from the, from the primary care or from the clinician. I would say, many times we're able to speak to the doctor right away in the lab, and, is this a chronic case of hepatitis? Is this an acute case? And sort of discuss the lab and work the case out thorough. Since the pandemic, with some offices being closed, primary care doctors, you might not get in touch with them, within a 24-hour period. So again, the cases are open a little bit longer, but, I feel that the case count in those types of diseases have been, they've been pretty low so far. And as well as influenza, I think I've seen only a couple of cases so far this year.
Mm. So, and then a lot of people are getting diagnosed by these freestanding testing sites rather than through their primary care. So,
Yes. And that's
So-
my other concern too, is this,
Right.
like with this new onset of the Vault test where you actually use your saliva for testing and then it's
Yep.
mailed away. Are we going, what's the timeline to receive that reporting? I've not seen too much of that yet, but I think with more people that are going to be beginning to use the home testing or to travel, choose to use that option, I'm going to have to actually look into that a little further.
you're talking about the one that you can get on Amazon, right?
Yes, that you can order the test.
Yeah.
It's a saliva test, and
Right.
I think you set up a Zoom call. They watch you spit into a cup, then you mail it off. I'll be honest with you, I do not know the lab that is utilized for that. If there's a number of different labs, and then what they do with the information. But I will definitely look into that.
So what do people think about supporting the nurses with this endeavor to follow up with contact tracing?
100%.
I think.
Nope.
Mhm.
I mean, Christine, do you have any info, any specifics of how many cases are lost to follow up right now in Reading?
Yes, and I would say there's been quite a few from. I'm just looking back to my notes. December 22nd to current, there's been close to 100.
Wow.
And that we were not seeing that. That's pretty new.
Do you
There may
think
have been a
this,
couple here and there, in the beginning when it was new, but people have been pretty good about, they want to receive the information, they have questions, and then,
Yep.
Once the guidance changed, there was a lot of questions there from cases, so it took a lot of clarifying there, but this is a pretty new, something new that we're seeing.
maybe this needs to go to incident command?
I was thinking this is certainly fits in with something we've talked about we want to keep the website fresh and providing information of what we know, and this would certainly be a piece of information and something to discuss.
For sure.
How do we message about this? And I mean, at minimum, making sure that the information's out there about why it's so important to have people respond to the case tracing calls. We've worked very hard to keep those case tracing calls to town staff intentionally, in part, to try and address concerns about people not wanting to speak with folks that are outside of their community. These are our
Right.
staff. We value them, and the information has a huge impact on all of the residents in the community. So,
Absolutely.
yeah, thanks for raising that, Paula. I think,
It concerns me a lot.
absolutely, same.
Christine, what is the nature of this event that's going to be on February 9th? Is this something that's going to be, well, you said a public forum. Are we inviting the public to hear a conversation about, how does that, how is it going to work?
Yep. So we certainly could invite the public. It is a presentation that is going to be put on by the contact tracing collaborative. If you'd like, I can forward that information if everybody wants to take a look at it. And if
Please.
agreed upon, we can post it for residents to log on because I believe they're going to be touching upon this issue.
I would love to be a part of that.
Yeah, if you can
Okay.
forward that, that would be helpful.
Sure.
And then maybe Carrie and Peter can raise this at Incident Command.
Yep.
I mean, it sounds like at a minimum, a blurb on our COVID vaccine website, the red one,
Yep.
not the yellow one, could be really helpful.
Yep.
Does anybody need help with wording or anything like that?
Probably not yet, but let's talk. We'll talk about it on Monday and see where we
Okay.
are.
Yeah.
But yeah, I mean, the issue is, making sure folks know that the need continues.
Right.
I mean, some of it could have been the holidays, but
Correct.
the other part of it is people are having pandemic fatigue and perhaps getting blasé about the whole thing. And that's a whole nother issue.
Yep.
That needs to be addressed.
Yeah, I think I agree, Paul. I think this is all, it's about don't let your guard down. I know people said vaccine, but that's not that's not permission to let your guard down.
Right.
Mm.
Thank you, Christine.
Yes,
Sure.
thank you.
Peter, any vaccination update or?
Yeah, of course, we can jump right into that, but I'd like to just spend one more moment with Christine here. You know, this is part of the job wearing staff down. I mean,
Yeah.
I'm going to say she's spending more time trying to get people to respond to the requirement of, the contact tracing requirements and coming up with, less information. But I mean, her day is chasing people for this stuff where it used to be a little easier to get them initially. And, now it's very tiresome trying to get these. And then you find data gaps all over the place. And just incidentally, well, how come the nurse didn't call me? Well, you weren't there to answer the phone and you never return calls. It's just one story after the other. And so before we go into the vaccine piece, I'd like to, bring up the idea of, kind of simplifying as much as we can this data as it's coming down the line. And Christine has been impeccable, at least in my estimation. And I know we've dealt with, different numbers at different times and, cleaning up things. But I'd like to ask the board if they thought it was appropriate that we, it comes from one source, all this information. I mean, we have been, Laura has been doing a thing every Wednesday on a daily basis, actually. I think we heard back, that it needs to continue on a daily basis. But I'm here to petition the board to see if, can we have it coming from one source, Maven, to Christine, to the public? And maybe it can be done, a little less frequently. It doesn't need to be done on a daily basis as far as I'm concerned, and I'm not going to go into my reasoning, but maybe you folks would like to, and maybe, Christine can add in too. But the point now, before we move to the next agenda item, is I'd like the board's input on, let's reorganize how we're reporting the data. And it is in some, Maven to Christine, and Christine can do it on a weekly basis to to the town in some regards. I would go even further, but I don't dare to, because when I was planning this out, I thought someone was gonna bite my head off. It's too much too quick. So on a weekly basis, Christine will give a report on the raw data from the town. And you know, just before I let this go for your discussion purposes, there is, as I understand, and I don't remember ever trying it when I was active on Maven, but Christine told me that there is a tab that can be used on Maven that will give a first responders report. And, you know, so part of this is police and fire want on a daily basis any new cases that are coming in. Now, where's the address in case we have to get called out to it? And I know it seems cruel and cold for me to say they don't need that, but it is based on, you know, good practices. I mean, police and fire, especially by now when they're getting vaccinated, they should be practicing universal precautions whenever they leave for an event. And I don't understand why they need a daily reckoning of.
They should be asking the
new?
questions. They should be asking the question when the call comes in. Is there anyone in the premises with COVID?
There's other ways to do it. But when we have all this information floating around, that's when we're getting the bad numbers. I hope my question was clear. I'm not sure if it is because I tend to carry on, but go ahead.
Well, let me just, you know, add to that a little bit. So apparently, what I'm told is back in April of last year, you know, the incident command asked that, and this was in the early stages of the pandemic, asked that the health division provide, I don't know, daily or weekly updates of the addresses of people in the town who have active COVID, so that if they got called to that house, they would know that there's an active case. So that was something that I think got put in place, and Laura has been providing this information to public safety on some regular basis, and with that idea in mind. A sort of second process, and these processes have been merged, but I think what Peter's saying is, should we just simplify it by separating them, is, you know, have Christine simply take the report off Maven of, you know, active cases, you know, resolved cases and so forth, and just send it out, period. And I think a weekly basis is fine. We've been doing it every Wednesday. And not sort of merge these two processes. So I think in my mind, two things. One is separating them out makes sense. It's just more efficient. You know, get a report, Christine can get a report off Maven on Tuesday or Wednesday and just send out the information. It then gets posted to the website. That's process number one. And then process number two, until it can be further reviewed by incident command, who originally requested it, you know, 10 months ago, Laura would continue to provide these addresses of active cases to public safety. On that latter point, you know, the question is whether Peter or Kerry can raise it at incident command that, do they really need, as Peter said, do they really need those addresses? I mean, we've come a long way since last April, and they ought to be practicing universal precautions. They ought to, like Paula said, ask, you know, about contacts, ask about COVID. They ought to have their masks on and their protective gear, and act that way. And sort of in addition to, they are now all vaccinated, or at least part one of the vaccination. And so one thing to bring to incident command is, you asked us 10 months ago to provide these addresses on a regular basis. It's a lot of administrative work in the department. Do we really need it? And so I think that's what sort of Peter is asking. And so personally, I would support separating the two processes, having Christine just report off Maven and send it out on Wednesday. Have Laura continue to send these to public safety for now, but then have a discussion at incident command as to whether it's still necessary.
Thank you.
I can live
Makes
with
sense
that.
to me.
Thanks for putting that in perspective, Rick. I can live
Sure.
with that, but I'm, usually not as patient. So thanks for toning me down a little bit on that.
Carrie,
So, my compliance training and the hairs are going up on the back of my neck that we have multiple sources of reporting of data. It's deeply concerning to me from a privacy perspective. It's concerning to me from a utilization of staff time. It's concerning to me from an accuracy degree. And I can't say any more strongly how much I want us to be relying on one source. There needs to be one source of truth. I'm
speechless.
flabbergasted. I am. I'm as speechless as I was when we went through the fun that we've gone through with the vaccine stuff recently. I'm so
Apoplectic.
so I just have to one source of data. So what I wrote down was we had the question about sources of data, the frequency, and then the privacy piece. And the privacy piece, that no disrespect in any way to our public safety partners. But just anytime you make lists and disperse them in other ways, you're increasing the likelihood of information being shared with other people inadvertently. And we have an obligation to protect the privacy of the patients and the residents, and I want to make sure that we're doing our utmost to do that. So
I agree with you 100%. There is no need for them to have that information. They should just be practicing safe precautions on a daily basis.
I mean,
So
And I'll
just to
take-
put that, I just want to put that in perspective, and I agree, Carrie, with you and Rick, your approach to this. But Paul, the reason that was put into play, and it was a lot of information and knowledge ago that it was put into
Yes.
place, certainly.
Right.
But when they were going out there, they were going out in full gowns,
Yep.
full masks,
Yep.
the shields, gloves, everything, when they knew it was a home that there was
Gotcha.
a COVID patient. in. So
Got
a
it.
little different, especially think back in April when we knew zero about, how
Got
this thing transmitted. So that's kind of where this bore from. They didn't want to have to get into waste all this PPE,
exactly.
which is what they would have done, right? So every
Right.
call now it's full gown, full mask, shield, gloves, the whole 9
Yep.
yards. That's what they would have had to have done back then. It's
Yeah.
a little different now. I think, the information is different now. And I think that's why it's important that we take it to them and say, hey, we kind of made this exception because of lack of PPE at the time and the
Yep.
need to go full bore, but we really need to scale this back
Yep.
at this point now, knowing a whole lot more about this
Right.
Yep.
disease. So yeah.
Yeah.
Just so everybody kind of knows why it was put in
Yes,
play.
thank you, Ken, because that's, I was going, after I took a breath, that was where I was going, was I know that these are very different circumstances
Right.
now than they were back then. And
Right.
absolutely understand the need, for folks to feel like they were being safe. And also, given the shortage that we had with PPE, it was, those competing concerns were really difficult times. So absolutely
was.
understand that this, is probably, it's a artifact related to what the knowledge base was back then. So I'd be interested in seeing how we can explore, what the utility is of it now.
I
Maybe
think
there's something we don't know, but I'm.
Well, this is
worried about
symptomatic,
it.
I think, of where we're trending in general. And we all knew it was going to go like this. So when you don't know anything, the alert flag has to go as high as it possibly can.
right.
And then you slowly back yourself down off that as information becomes available. The problem you run into sometimes is some people are reluctant to actually back it down,
Yes,
even with the information in front of them. So,
Yep.
you know, it's one of those things you have to kind of work with everybody and get everybody comfortable around it.
Well, I think they can use the example of how the hospitals and the practitioners have gotten patients back into being seen in person and doing these screenings at the time that
Yeah.
they are presenting themselves, you know, and if they,
Yeah.
then from that point, take whatever precautions are necessary.
yeah, no, I think this is good. We can take this to command and have a conversation and understand, you know, there. So that makes sense to me.
Yeah,
Peter?
Well,
when Peter and I talked about it, we just, my initial reaction was, let's just stop doing it. But then, you know, from a political point of view, we should have a conversation before we do it.
Yeah,
Yeah, I think, you know, Paula, I think nails it right on the head where it's now just a part of their script, right? So does anybody in your household currently have COVID, right? It's a very simple question. They're walking into households with people that have COVID that don't know they have COVID anyway. So it's not like, oh, well, what if someone's asymptomatic? Well, you're doing that right now anyways.
that's
You're
right.
not putting on the full gear. You're not, you know, so, you know, it's really just a simple question to add to your script when the call comes in.
Yeah,
Okay, Peter, I think you got your answer.
yeah, I took us on a tangent.
no,
From Todd.
this is important.
That is important. Yeah.
Yeah,
I mean,
thanks.
the accuracy of our data and whatever we can do to make sure that our data is correct is very important. And then the question about, you know, what we're doing with that data is absolutely very
The
important.
protection of it, sure.
Yeah,
Well, so now as we slide into the vaccine update, I would just assure you that in talking with Christine, she assured me that this is something that she is capable of doing. So I don't feel like we're job loading her. As a matter of fact, it might even be simplifying her life by letting her, you know, do what she does. And she can continue doing that well. So we don't need to kick this any further down the street. Let's talk about the vaccination update, and Swang's here too, in case we want to hear from her. But let me just mention that the vaccine is in town in a limited amount. We're finishing up our phase 1 tomorrow, and then we're going to begin the second dose of phase 1 and the first responders particularly, and the second dose of phase 1 the following week. But the good news here, and it's limited good news, is that we have 100 doses of vaccine that can go to the phase 2, 75-year-olds and older. And this is, you know, what we've been waiting for. And it appears, and I can't commit to it really, but it appears we're going to be getting 100 doses a week. So now Twang is, you know, was a marathon, everything is a marathon, so you want to pace yourself, but I think she's going to have to pick her pace up. In order to get those 100 doses, we have to be able to project 2 weeks in advance when our next clinic is going to be there and start to fill it through Prep Mod.
Yep.
And so, Twang, is this a good time to lead into, you can talk a little bit about the plan that you have for the rest of this week? We can see a screenshot that Twang captured,
Sure.
and she can
Sure.
show us
Yeah.
some discussion.
Okay. So this is the screenshot that I get this afternoon around 3 o'clock from PubMod. So as you may know, we have.
We need some more volume, Twang. We can't hear you
Oh.
well.
Okay. So
better.
So this is the screenshot that I get the snapshot around 3 o'clock this afternoon, and it's from PubMod. It's regarding our 4 COVID-19 clinics, COVID-19 vaccine clinics. So as you may know, we have already vaccinated 96 first responders and healthcare personnel with first dose in the past 3 weeks. And tomorrow we have vaccine clinics with targets 70 doses for probably the last group of phase 1. And starting from next week, we are going to have second dose clinics for phase 1, 96 people. So on this February 9th, we are going to have the second dose for up to 80 participants. And on the 16th, we will have up to 20 people. And in the meantime, phase 2 will start, and we already scheduled a 100 dose clinic for 75 plus seniors on February the 12th. And like Peter said, we will receiving vaccines like for the next week. So we expect to have more phase 2 clinics and the second dose clinics in February. And like you can see, so for tomorrow, we already had 54 people registered for the clinic. So everything is running very well. And with PerpMod for vaccine clinic appointment, it could be potentially help phase 2 and phase 3 public to make their appointment for COVID vaccine clinic. And so for tomorrow, the location is at Reading Memorial High School Fieldhouse, and I went there yesterday, took a picture. Let me see. Yeah. Okay. So yeah, I went there and it looks very beautiful because they had senior nights over there yesterday, so I could not enter the building. So this is the location where tomorrow's event will be held.
Can you put back the screenshot, please?
Yeah.
Shuang, I have a couple comments that are compelling, and I got to get those out. So the third one down, okay, let's start with the top one first. There's 54 people who have scheduled through PrepMod for tomorrow.
Correct.
And I think there's 70 doses that are available. Correct me if I'm wrong.
We target 70 doses, but I'm working very closely with the fire department to make sure we have bring in the appropriate amount of vaccine, because we need schedule in groups of 10. Moderna vaccine is 10 doses per vial, so we must finish using all vials in the event, and we cannot use any left over for the next event. So that's why we always target like 60, 70, 80.
Okay, so the point about the 54 when we have 70 is this, and it goes to a conversation I had with Paula earlier this week. And it turns out that she is married to a guy who's a member of the clergy. I forget exactly what his title is. What is it, Paula?
He's a deacon.
Oh, he's a deacon. Thanks. And so it's my belief that these folks who visit the sick, especially in the nursing homes, are phase 1 eligible. And we have 54 members signed up for phase 1 group, and we have 70. So I've been hedging with you, Paula, because the fire department is thinking they already have the extra 16 folks in waiting, but if they're not registered, and they're even challenging me that clergy is not a phase 1 eligible person, and I guess we have to wiggle that around. So we have until tomorrow at noontime, and I don't mind. I mean, I'm an advocate for the clergy that have to go in and give rights to the sick and last rites, whatever we're calling it these days. Oh, Carrie, do you know the answer to that?
Yeah, I'll take that. I'll take that conversation. The clergy are absolutely
Thank
eligible.
you. All right. And I'm not going to go into detail here, especially in public, about some of the creative ways we're not going to waste vaccine. That's
Right.
the only thing that is not on the table.
That's what
We're
this
gonna
is about,
Not
right.
waste it.
100%.
But we do
Right.
want to give the good old college try to get it into the arms of the right people at the right times. And
Yes.
so
Yep.
I would now invite Paula to, and I know she has a busy day tomorrow and so forth, but I left you hanging for a whole day only because these guys, it's just tough sometimes trying to figure out how we're going to get our point across. So there's my point, and it's across. Now, even more compelling is the third clinic down where there are 100 doses, but we have 0 registered, people who are registered for the vaccine. And I bring this up because we're going to have an update for you soon. This is a command thing that we're talking about. As you may or may not know, we have been keeping Gene has put together a phone bank, and we have significant numbers of people signed up in that phone bank. But this is a real example of how do we allocate the resources that are available. And so
Yes.
it really comes under healthcare rationing, and it's an ethical thing on how do we get 100 people at a time, and who are the first 100, who are the second 100. Everybody has to be 75. That was the easy part. The state did that for us, but we have hundreds of people over 75. And when do we let them come in? And this is something that I really feel the board should at least have a general idea about in case you have thoughts, and they would certainly be welcome. Healthcare rationing is never going to be fun. And this is a first test in my lifetime where I've had a chance to at least see it close up. So that's out there. And this is what's going on with vaccines. The pictures that I sent in your packet, Schwang showed you the outside, but you saw the layout of the school. And this is a good thing. At first, we're overkilling the heck out of this, but it's important. I believe in Jackson when he says that we need to stress the system that we've been working on so long. Every city and town has had an EDS plan that, and Kerry mentioned it earlier, that we revise annually, if not twice a year, and practice on. And this is our EDS plan. Board asked for this last month. Those pictures show you what our capacity is. And if we had more than 100 doses, we could do more vaccinating.
Yep.
So I hope those pictures were helpful in visualizing that. I hope the screenshot that Schwang showed you is helpful in visualizing how PrepMod fits into the picture. And then everything in between is like the heavy stuff.
So the question is about strategies for identifying people that are eligible, and how do you go about, if you have a limited number of doses, how do you go about allocating and deciding who gets them? Is that what we're?
Oh yeah, there's models, first come, first serve.
Peter, I had heard, is there about 300 people on that list?
I just got something from
Yes.
Senior and Social Services. Gina,
Yeah.
can you help? I mentioned it earlier.
That's about,
That's about right. Okay.
Yeah.
yeah,
that's
they're-
what I heard.
So in my mind, if in the ideal world, you'd want to start with the most. There are people over 75. There are different types. There's some people are still playing golf, twice a week, and others are frail. Others have multiple conditions, and others don't. The problem is that you can't tell that obviously from just taking the list. If we were a health system that had medical records, we could use informatics to pull out the high-risk patients and go with them first. I just don't see how, as the health division, it's easy to do that other than first come, first serve. I suppose the only sort of reassuring part is that, well, with 300 people, and if we're getting 100 doses a week, in the next month, we will get through to them all. But even those, at 100 doses a month, we're not going to get to our 75 plus residents for months, unless the spigot opens up, maybe with this Johnson & Johnson vaccine they just are talking about. But so I would say first come, first serve. I don't know any other better method, but maybe someone does. Yes, Paula.
What about the folks who don't have computer access? And there's a
These-
lot of those.
Right. So these, I think we were thinking of going to the ones that were calling in last week saying, can I have when are you going to schedule, vaccination clinics? And of course, we hadn't really processed this and gotten as far as we did, and we didn't have the doses. And so we started taking names. So I think we're just talking about the several hundred people who we took names for. That we can
okay.
call back and say, you can now register.
Oh, okay. I misunderstood. I thought the 300 you were talking about had already registered on PrepMod.
No.
No.
Okay, I misunderstood.
And I'm presuming that when we call back, if they're not computer savvy, that we have staff or maybe the nurses at the senior center or our nurses can actually support them in doing the registration.
We, if I could, we have a mechanism for assisting people. So that hasn't been fully rolled out yet, but that's something that I've been working on with my fellow department heads. And we've identified, just like with the clinics, we've identified admins who can provide support at the clinics. We're also looking at reaching out and using maybe those same admins or maybe others, but I'll be reaching back out to my fellow department heads to see if we can, for lack of a better term, create a phone bank. It wouldn't be a physical phone bank because we don't want people gathering, but we've been working with IT on the concept of a decentralized phone bank with existing staff who could assist people and get them up on PrepMod.
Great.
That's great.
Paula?
I'm concerned about HIPAA.
In what way?
Well, we've got people who are taking personal information from the public. Insurance information, because not there, I think PrepMod is asking for that.
Yep.
It's a concern.
Yeah.
But if the person is volunteering to share their information.
Right.
um,
There may just need to be something else they sign off on that
Yeah.
there's acknowledgement from them that they're sharing the information. I don't know, Gene, maybe you can think on that, but that would make sense, Paula. I think if they're signing off on something, then it's fine.
Yeah, because it's not access to a record. It gives them the tools to get access to a record, but they'd have to go through a lot of hoops to.
Yeah,
to
I mean, they get
that.
all their data. I mean, name, age, date of birth, insurance.
Only to be entered in the PrepMod thing, which doesn't let you save or print out. There's not that kind of access. So, I mean, it's a good question. I'm just kind of pacing through the steps of it. I'm not, I'm trying to.
It may be that the person who is helping the resident, has to make a statement. You'll have a statement that they read, and then the person agrees, and then the information is transmitted.
Yeah.
And maybe that's something legal needs to weigh in on.
Sure.
Yeah. The thought I have around this all, and it always circles back to, we don't want to waste vaccine, is these seem to be private events that we're setting up. Is that correct? So if I was to go in PrepMod, I will not see Reading Memorial High School pop up.
Right.
I think you can't make them private if you want to try to make sure that you maximize your vaccine. I have seen that other places are restricting to certain communities only. In other words, only these 3 communities bother showing up. We're not going to take anybody from outside of it. Is there something that doesn't let us go public with it, yet with the disclaimer that this is for Reading residents only? That would be my question.
I know that at the vaccine, and Christine and Shuang, you can weigh in on this, and Peter and Jean maybe, but on the original couple of clinics, Paul Jackson had a list of people that if there was extra vaccine, he would call them and say, we got some, can you come down? And
Sure.
that's how it happened.
Right.
But that list is going to go away when we get into the general pop,
Right.
general pop, right?
Right.
So
Right,
that's
no,
not,
I'm just talking about the private clinics.
and I guarantee that out of those 300 on that list, you could probably maybe cut it in half, those who already have appointments by now.
Right,
Because
exactly.
once they got on a list and then their sons and daughters called and said, wait, you don't need on a list, I got you right here. So I think the more you have it in the general, open to the general public with the disclaimer that it's for Reading residents only, I think is the less likelihood that you're going to waste vaccine. That's my opinion.
So I was, correct me if I'm wrong, Peter, but my thinking was that these private clinics are cleaning up phase 1 for residents in phase 1, and second shot for first responders, and working through the several hundred people who called in, made sure that we got back to them. But once we get through that, that we would in fact have, as Kevin said, have it public, Reading residents only, phase, whatever it is. Is that the way
Yes,
I'm
it is.
supposed to be looking at these private clinics versus public? That is,
Yeah, you have it
public
right.
ones are coming, but we have to finish the cleanup for what we started.
Yeah, the cleanup, it includes I'm looking at it right now, the 358 names that we collected, of which 281 are over 75. And by the way, there are 750 residents that are over 75, and that's according to some information that I'm not sure where it comes from, but that's coming in from the senior center. So I would say that, yeah, cleaning it up, and you got it exactly right, Rick. Let's clean it up before we go public, and that would be just in a few weeks.
And then, once that's done, then, I've seen other communities, including another one that I work for, and they throw it up with 100 doses and it books within 30 minutes. The appointments are gone, but it's public, and you have the full disclaimers of who it's for, and people will be turned away. There have been people showing up at other places or registering before they're eligible, and they have to be turned away if they're not caught before registration. But first all those folks that called definitely have to get cleaned up. And I just want to sort of take us aside for 1 second, and if I may, and acknowledge the unbelievable amount of work that the folks in the town have been doing since this information about vaccine shifting happened. The phones were ringing off the hook. People didn't have information. They didn't have the answers. And I know just from some emails and different conversations, I only have an inch of visibility into it. I know how busy everybody's been, and the work that's gone into trying to pull together the phone bank, the work of keeping track of the list and who was doing it. This all came out of nowhere, and I can't say enough for how people pulled together and just figured out how to tackle it and move forward. And I think it's important to acknowledge that, because I know there's a lot of frustration out in the world, and I'm sure you guys got some of it. And I know how much work was going in behind the scenes to try and get it squared away. So thank you.
I
Good job
second
pointing that out.
Carrie. Yeah,
Thank you.
I know that there's been a lot of abuse taken on the part of staff, and the tensions are high.
High. And Jean, I don't know if it's in your job description to pull together a phone bank to do this, but thank you. Figuring out how to do a call center, and lots of people, but thank you. That stuff won't ever get seen. It just kind of happens quietly behind the scenes.
Yeah, I just wanted to point out that the Executive Office of Elder Affairs has, we've been on calls with them, and they've encouraged us to help seniors that don't have computer access. So, that's we can figure out the mechanics of this, and I think Paula raises a good point. But just to put it in perspective, that's the call that all of the local agencies are getting and all the local municipalities are getting. And we're working very closely with our elder affairs staff so that we can be a resource. So, you know, we're here to serve the public. It's an easy and fair path, but that is the ultimate goal for us to get these people what they need. So just want to add that.
Yeah, I
Thank
think
you.
that's a legal resolution, not a hurdle.
So Peter, can we wrap up COVID? We have civic recreation and we have any updates from Paula, but are we gonna?
Yes. Thanks for bringing up Paula again, because she should have probably, I should have recognized her back when we were doing the monthly report from staff. And Paula has been tracking, you know, the special project we have going on out there with, you know, the safety guidelines at food establishments. And so can I turn it over to Paula and then jump right back here and give you a quick review on what's going on with the civic permit issues?
Sure, thank you. And I see Laura's on here, so Laura, cue in if you have more to add. So Laura had created an Excel spreadsheet with all of the local food establishments, and per incident command, she was getting the mask up and the social distance and hand washing and all the protocols that are supposed to be followed on a flyer, and handing them out to each of the establishment and establishing rapport about support with these establishments. It took a while to get the flyer together because there was some, I think we had the Reading logo on it and we had to go back to the Massachusetts one. And so it wasn't ready until last Thursday. There was no work on Friday. And then Monday we had the snowstorm. So as of yesterday, I guess, she's gotten out to 6 of the establishments thus far, and all of them already had the flyer that they had downloaded themselves from the website, from the Department of Public Health.
Wow.
Of the 6
Great.
that she's had. And she, so she was just letting them know that we're there for you. You know, if you need help. And she said that they've all got her cell phone number anyway. So she has that relationship with many of the establishments. So that's where we are, more to come.
Okay,
Okay.
great.
Did I leave anything out, Laura? Maybe she.
Nope.
Okay. Thank you.
For the
Thank you.
first time in a couple
you,
of months,
Paula.
we've had permit issued rather for civic functions and recreational functions. So I'll just mention that there were 3. The third one I haven't approved yet, but I was notified by Jackie earlier today that somebody chimed in today. They want to be able to sell Girl Scout cookies in public. I'll take a look at that one later, but so that one is pending. The other 2 are the typical. Let's give thumbs up, and I always do whenever I can anyway, for scouting. Girl Scouts and Boy Scouts want to use the town forest to have safe outings there, just for an evening of, you know, campfire, get them out of the house and so forth. But you know, it's been pretty easy getting in touch with these folks, having a quick interview with them over the telephone, making sure they understand everything that needs to be done as far as distancing, and if they are going to offer snacks and how's it going. So that's all working out just as we had intended months ago. And let's see, at the same time, you did get the final version of this public skating sign. Any comments on
Yep.
that? I hope it's exactly right.
Look good.
Look good, look simple, which is even the most effective way to do it.
Yeah, I know. Thanks to Kerry for putting that little zigzag thing. Forgive me, my generational piece going on here. But they were printed the last I heard, and then they were gonna go get hung when the storm started to hit. So I'm not sure where that piece is, but has anybody seen them yet? And I knew Rick lives near one and Kevin, I think, lives near a skating. rink.
I haven't been there. Actually was near the Sturgis Park and to look to see if anybody was out there skating. No one was. This was this afternoon. But I didn't get close enough to look to see whether they were posted or not.
Okay.
Yeah,
Well,
same. I didn't look to see if they were posted either.
well, if you think of it, I mean, some feedback would be good. I don't know if they're gonna withhold the weather. I think they were supposed to be laminated. Look, we went through this process, and so there was a beginning, a middle, and a finish. We'll find out how to evaluate it once we see the signs hanging and how long do they last before they turn into, I don't know what happens in
Hopefully
the
they'll-
springtime, slush. But
Hopefully they'll get them up soon.
that's all I got under that item, number
Okay.
8.
So let's go to this item number 9. And, you know, I wanted to get everybody's sense of kind of what the year looked like, because sort of over the last few months, we've talked about doing different things, and the question sort of becomes, how do we line those up in terms of our agendas and the work we should be doing over the coming year? I have never shared a screen, so if this doesn't work, then I will, let's see, how does one do this? Actually, I might even ask Jean, or you know that PowerPoint that
And at the
You're-
bottom, Rick, you should have a green tab that says share screen.
yeah, okay,
Click
and
on
then,
that.
oh yeah,
Do you already have your PowerPoint up?
is that it?
There you go.
Oh,
You
wow.
got it.
Gee, I'm a technological wizard. Okay.
I haven't done it yet either.
Okay, so let me. This is a really kind of paltry attempt for me to use PowerPoint, but I think it gets through the information. And let me walk through this, and then I want your feedback if we should be moving these green boxes forward or backward. So the blue line is January through December. And the first line, the first green box is, you know, our efforts with COVID and the vaccination effort. Obviously, that's going to be ongoing through the course of the year. The second line is recruiting a health director. And, you know, there's a possibility that we may be able to begin doing that and not have to wait for the town meeting to get final approval. And so as soon as Jean and Bob tell us we can move ahead with that, we would begin that process, whether that's in February or March. I'm hoping we can start, because I think it's going to take a while to get candidates and so forth. At some point, we would have a new, now going down to the third row, a new health director in place. This sort of lays out, gee, you know, if we could post it in February or March, maybe by May or June, we could have that person in place. It could very well be that that person isn't in place till October. I don't know what the job market is for health directors, but I'm told that it takes a while. So the next row, the fourth row, is this idea of an RFP for an internal consultant. And obviously we tried this before back in November. We decided, because we only got one response, to put it off for January, February timeframe. So this is January, February timeframe. That's part of the reason I'm bringing this back is, you know, do we want to do a limited RFP for a consultant, possibly even with the organization that did reply. And mainly to look at, how the board's functioning, how the division is functioning, how we stack up compared to other communities like us in terms of processes, systems, resources, and so forth. And so one approach would be to actually launch that now and have the consultant come in the May, June, July timeframe, do his or her work, and then report out. And sort of that's sort of one way of doing it. It has the advantage of having the health director in place working with the internal consultant so that the health director could, get oriented and kind of establish him or herself while the consultant is obtaining information. And so when the report for whatever internal changes comes out, the health director is there to be able to take it on. And that would be one way of doing it. Another way of doing it would be to wait till the health director's in place, then do an RFP, maybe even wait 60 days that the health director's in place and they got their feet wet, then do an internal analysis, with the health director. You could go either way. So there's some question, I'd be interested in people's thoughts on that, whether to do it, later or sooner. And then the last three rows are, actually the last two rows are, we talked about doing a community needs assessment and a community health improvement plan, which is kind of the, at the top of Maslow's triangle here. I mean, it's something you like to do and take a bigger picture and of what the community needs in terms of their health. But I don't think that, we would be ready to do that until the second half of the year for two reasons. One is we have to kind of get through COVID. And I'm hopeful that by the summer, we've gotten through a lot of the vaccination issues. And secondly, I do think we need to have the health director in place to be able to orchestrate that effort with the consultant and the board to do the analysis and then to do the project itself, which would be implementation. Of course, the implementation typically is multi-year, not just a few months. So that's what this is about, and I'd be interested in folks' feedback about. I'm sure everybody would agree the sooner we can begin recruitment, the better for health director. But thoughts about this internal consultant, should we do it sooner? I mean, we could do it even, we could do it even before the health director arrives and then hand it to him or her. The downside of that is that he or she would not have engaged with the consultant themselves to feel some ownership around it. That would be the downside. The upside is we'd have it in our hands sooner rather than later. And then I think the second piece I'm looking for feedback is really, does it make sense to do the RFP for the community needs assessment and the CHIP later in the summer or early fall once the health director is in place. So that's I'd kind of open it up to the floor. Paula?
So my question is actually to Peter. Have you been through this kind of an experience yourself in terms of having the internal analysis done, consultant analysis in your other job, previous
I'm
job?
thinking right now, well, we have done the top of the Maslow pyramid with the, community health needs assessments and so forth projects. But really for an internal consultant, we never did.
Okay.
We,
No, I just was
sorry, I
asking
don't
to
have
see if you
to-
could shed light on that, on which way would be better. So, because I don't have a sense of one being better than the other, and I just didn't know if you could shed light on that.
Truthfully, I don't know what the market is out there right now. There's a lot of MPHs. I don't know how green you're willing to go. And, if we recruited right at the, the graduate school level and had some kind of a plan where the person could come in and, cut her or his teeth at the same time she or he is learning, that might work out in terms of the timeline. And I don't have a problem with that, especially if you kept, and I think I've heard part of the plan is that you would keep, someone like me in place for a little longer to help with the smooth transition with the new person. To try to find an experienced health officer who wants to jump from one town into here, I mean, mostly it's about money. And, if somebody working in, big thing is in-ground sewage disposal. If you're working in a town that doesn't have municipal wastewater, you're stuck doing perk tests and, you go to work. It's a different job. And when you come to a place like Reading, or where I was in Danvers, and, get some of the real good stuff. I mean, it's not so much salt of the earth. I mean, we need wastewater disposal, let's face it, but you come in every day. And so maybe somebody from that angle would like to shift it down. I don't know. You can start to. So I guess it would depend on if you had someone with some experience and would come in with some good ideas, be progressive about it. And I mean, I like to develop folks, and I think the internal consultant would be a great learning opportunity if we had the right person here. And it gives, I think Rick said it, but kind of processing gives that person a chance to not so much be invested. I know that's the other side of the coin, but to kind of grow with the program as you're getting in there. You get a sort of honeymoon period, and this would be, gosh, look at all the things I get to work on. Now let's put them in order and begin the implementation. So I don't know if I talked in circles there or not.
I have a comment. So it seems to me like this is very, I think, to what Peter was saying, this is very person to person in nature, depending on skill level, qualifications, what have you. I think a good course of action moving forward would be to go ahead and, put out for the internal consultant and have a timeline for them that is to be determined. To me, this is a great question to actually ask of any applicant that's going to apply for the job is, how would you want to proceed? This is what we intend on doing. Would you like us to just drop this information in your lap on day one and you can hit the ground running? Or do you more prefer to work with this consultant along the way in developing an overall plan? And I think you might get different answers from different candidates.
Right.
So I wouldn't want to hamstring the potential new hiree into our shoes, but allow them to be the ones to kind of work through that option of how it gets implemented. Like I bet you'll get different answers on that question.
Interesting. Okay.
I definitely agree with the needs assessment, to push off until later in the fall. Certainly, I think that's probably a smart timeline for that.
Okay, so I mean, I think you're right, Kevin, that it would be an interesting interview question. I think that it reveals preference and it reveals working style. For me, I go back to what's our intent with doing this RFP and having this consultant, and that is to essentially establish, if you have kids, they're all asking for the rubric right? What's the rubric? What do I have to do to be successful? And that's really what we're kind of looking, what we're hoping to get some guidance from this internal consultant. So I think that how someone works with the rubric is yeah, it's preference. I don't know if I let them decide. I'm not I'm not convinced on that yet. I definitely would want to know how they respond to that and what they you know, what their work style would be, certainly. In terms of timing of it, I mean, certainly putting it out and seeing what we can get, I think that that would be good. I do want to respond to one thing I heard you say, Rick, about possibly using the vendor that applied. And for me, the important priority is that this be someone who has actually had experience in a health department. And I've said this many times. MAPC does great work on all sorts of public health adjacent stuff, but they don't actually have public health experienced folks on staff. And I feel like that's very important. So just want to put that out there since I heard you say it. Yeah, I think otherwise it's kind of like, well, I'll use the example. So we talk about the current registration system discussions that are happening about registration for vaccine. There's a fabulous product out there that was developed by Deloitte and Touche, or just Deloitte now, that the CDC rolled out, and it's in use in 10 states, and it's a mess. And it's something that was developed by a consulting firm that, you know, said, well, we can do this. Whereas PrepMod certainly has its flaws, but it was developed in line with public health clinic functioning. So that's the kind of thinking I have in terms of what we're looking for a vendor. And I know we didn't get good responses. I don't know if there's a way that MAPC could find a public health person that would be willing to sub out with them and work on this for parts of it. You know, I don't know. I think we can think creatively about it, but I do think it would be good to get it out there and see what we can accomplish with it. Yes, push off on the community health assessment, certainly. And yeah, I don't know where we'll be with the recruitment for a director. I like what Peter's saying. You know, there may be some people who are graduating that have been part of that academic public health volunteer corps. They're out working in communities. They've gotten a taste for some of this stuff, and they may be very interested in working in a local health department. And if they're graduating, they're starting to look for work now. So that's, you know, that's a very possible source of applicants, and that could
That's
be
a good
very
point.
interesting. Yeah. So, yeah,
So I guess to what you're saying, Carrie, it really depends on the consultant who comes back to us, right? Because if you have somebody like MAPC, for example, and that's your option, then you definitely want the new hire to be working with them one-on-one, right? Because they're going to give them the health side of it. No, you don't do it that way. Here's why. Oh, okay, right. So a lot of it comes down to, I guess, who the consultant and who the applicants are. I think that's kind of more my point. I think we have to be a little more fluid with those two factors and not necessarily confine it to a timeline or a peg before the other type of thing.
Yeah. There's no, so yes, I understand. And it's just kind of a dance. I get that. Yeah, that's a great observation. I think that a student, you know, somebody who's just out of a MPH program is not going to be someone who's able to provide that kind of feedback. So
right,
we have to figure out how, you know, how we make sure we get it, I guess. You know, if it is MAPC, how, you know, what can they do to make sure that we're setting the new person up for success and setting the town up for success and the like. So,
and maybe part of this is Peter, you know, twofold, working with a new hiree and a consultant to kind of make sure everyone's knows where we are, knows where we came from, and is moving forward in a cohesive unit.
Yeah.
Jerry, do you have any thoughts on this?
Yeah, I mean, it sounds like if we have anticipated budget, it makes sense to get these open
Mhm.
and see what, comes in. And everything you guys had said already, as far as knowing what we want out of the consultants and knowing what we want out of the health director is going to be important to us, because we're going to have to guide them.
And one of the other considerations is how long, what the recruitment for a health director, how long that will take. Like if we're sort of drifting into August, we still don't have, a candidate, we still haven't made a hire, if we feel like this is going to take much longer to get a health director in place, we may want to do the analysis, just get it done so that we know, we have it. And Peter would have to be the sort of bridge between the analysis and whenever we got a health director. On the other hand, if the if the recruitment process over the next month or two, if that's what we're able to do, seems like we get some good candidates, then I think Kevin's approach of, engaging a little bit, but sort of doing it in concert kind of makes sense. I am concerned about how exactly, just because I don't know how to do this, how exactly one identifies experienced public health consultants to send out an RFP. Where do you post these things? How do you, it's not my area of expertise.
Really, in my experience of this, it's retired guys who have done it and have a background that was, basically flawless. And then there are guys out there that are still members of Mass Health Officers Association and so forth. And Kerry and I, we talk about a couple of them that I'm still sort of friendly with, and they'll work when they, when an interesting job will come up. But really, you can't go to a headhunter and try to locate one. It's it becomes a word of mouth. And do you know somebody who knows somebody who's done this? And find a town that was well run. And what happened to that? Whatever happened to that guy?
Yep.
And let me see if I can, dig him out and see if we can make it a little bit interesting to him. As long as it's not overbearing, he might come and share some of his expertise. It's nice if they had some background in curriculum, and there are those folks out there. Some of us retire and go into teaching at a junior college or a college level, teach a class or something like that, and that shift is pretty easy to make. So there's a way to get some feelers out. That's how you would do it, Rick, I think.
Okay.
I have a question. Rick, you had mentioned a long time ago about working towards accreditation. Is that something that we're actively seeking? And the accrediting agencies, would they have people who have gone through this process that have led to successful accreditation?
I don't know, Carrie, do you know the answer to that? Because I know that there's a national organization that does this accreditation.
Yeah.
Whether they have access to local consultants, which would be great, to help a board achieve that. That might be a place to, find someone. What do you think?
Accreditation happens where you get an accreditation team that will roll out, and it's just like school accreditations or whatever, right? So it's experienced professionals that go out and do the assessment based on the existing rubric, and they meet and discuss the scoring and so forth. So those are folks that usually are currently employed and, figure out a way to fit it in on their thing. There are some retirees. So accreditation right now is still it's a regional and it's a bigger city achievement. Accreditation is a high bar. I think in the state right now, City of Cambridge is accredited, Worcester is accredited, Boston is accredited. and the state DPH is accredited, and that's it. And there are a handful that are working to pursue it. But it's a multi-year process. So I think the problem is the consultants would be that their level of experience wouldn't hit right. And Peter, jump in here, but I think their level of experience would be such that it would be hard to translate to a smaller community. Do you agree?
Yeah, you're right on. The small community, it's asking more than most small communities can handle. This accreditation piece been around for a while. We've given it a lot of thought in my previous life. We tried to do it across borders and see if we could do it as a region. And there's just too many. I mean, it's, a health department in a county setting in another state or in a big city, as Kerry said, is comprehensive enough to cover all the core requirements to acquire accreditation. And it's really not feasible to do it at this level. So it's a good question, Jerry. It's one that we've all been wondering for a long time. How does it fit here? It doesn't fit in Massachusetts.
Yep.
Yeah, no, I think that's just part of understanding what we want out of a consultant. If it's not attainable or not feasible, then we should not look for that.
Right. Actually, that might have increased the price. That why we didn't get people coming back, because they said accreditation. That's a whole other big piece of work. If we can scope down to just, not blocking and tackling, it probably will be a easier way to get someone.
Right. Yeah, I mean, it's a good indication of interest and seriousness about treating the public health role and the structure. But yeah, no, I think you're right, Rick. I think it may, hadn't thought of that until you just said it. It may very well have raised the price tag, thinking of what needs to happen to get to that. I really hadn't considered that. I bet you're right.
Yeah. So what I'm going to take away from this conversation is that we'll know within the next 3 or 4 weeks about whether we're able to begin recruiting for a health director or not. It's sounding positive from what I hear, and then when we begin that process, and we should probably have a discussion in the board about that process, by the way. And meanwhile, let me see if I could work with Peter and Jean around scoping what an RFP would look like if we were to do one, and trying to line up some names of people who we could go with, but not sort of pull the trigger until we see how things are going over the next 4 to 8 weeks with recruitment and so forth. And we'll push the CNA and the CHIP off to the end of the year. Okay, that's helpful to me, at least.
Great.
Okay.
Good conversation.
Good. All right, anything else?
I have a question, and
Yes.
I think it's probably maybe directed more to Carrie than anybody else. I'm hearing a lot of talk about double masking. I just don't see people doing it. I mean, it's hard enough to get them to wear one mask.
Oh, I know. Well, and it's it's come out of a few places, but I know one of the places is Dr. Osterholm at CIDRAP out in I always get it wrong, but I don't know. I think focus on getting people to wear a mask and getting them to wear a high quality mask and be compliant. If I could see fewer people with the mask below their nose or around their chin.
Or the gaiters. The gaiters, get rid of those gaiters.
Yeah. Well, I mean, even gaiters, if they're gonna cover their face, yes, I'd rather see a mask. And I'm curious what, Rick, maybe you guys have talked about it at MMA. But I don't know, it's.
Well, I mean, there's a theoretical argument to be made that double masking, if we believe that the viral particles are typically associated with respiratory droplets,
Yep.
And that if you have two layers, it's sort of like, you know, the Swiss cheese, it has to go through, you know,
Yep.
two holes in order to get to you. Therefore, 2 layers is better than 1. That's the theoretical. I think it's going to become more of a topic if the variant becomes pretty widespread and people are really concerned that it's just so highly infectious, 1 mask isn't enough. And maybe by then, and by then could be in the next couple months, you know, maybe there'll be some more research out there about whether it's actually worth doing.
Yeah. And this reminds me of something that I wanted to raise. So we heard a great presentation on one of the local health calls about developing technology that relies on cell phone data proximity, and it's the little packets that
I've heard of that.
yeah, and it's very in development, but there is some real interest in it, because if you then identify, if you are someone who was who tests positive, then that information becomes part of your package, and you can activate that and let people know anonymously that they were, if they were within proximity, that they can be told that they had an exposure risk and that they should go get tested.
Weren't they doing that in Korea at one point?
Yeah, that sounds right. I just heard they're so it's being discussed here in the States, and I don't know where it is in terms of rollout. I know that there's lots of privacy concerns and discussion, but
A little bit Big Brotherish.
it is, but it's it's the what made me think of it was when you said, Rick, the Swiss cheese piece, because this was how it was put in context, was this is another piece of kind of a Swiss cheese. You want to block all the holes, and maybe here's a way to block the holes and get at those unknown community transmission cases. So
right.
Yeah.
So this phone thing is that if you turn it on, if everybody turns it on,
right,
then and you suddenly get COVID, you can go into your phone or maybe it's through a website, and they can basically, anybody using Bluetooth, anybody who was 15 minutes or more in your contact in Bluetooth range can be contacted to say you were exposed.
Yep.
It does seem Big Brother.
It definitely seems Big Brother. Yeah, and that's a key piece, Rick, what you said about, if it does depend, and success depends in part on participation rates.
Right. Right.
So if people are willing to have that information be shared. So there's some work to be done in terms of what is the real privacy risk. I don't know, but it was serious enough that they were talking about it to us, and they wanted to share the information. So
interesting.
Yeah. Who knows? Wear your mask, right?
Wear your mask.
Yeah, wear a mask over your face, a good quality mask.
Hey, Port.
Okay. Motion to adjourn.
Okay.
Roll call. Paula.
Yes.
Harry.
Yes.
I love you all, but I'm tired.
I know. Good.
Thank you all.
Have a good
Great
night.
meeting. Thanks, folks.
Good
I
night,
appreciate it.
everybody.
Good night.
Thank you. Good night.
Right.